Hello, we'll see empyema thoracis in this video. Empyema is pus, thoracis means the thorax. Thorax has a huge cavity, it's called the pleural cavity. Empyema thoracis is nothing but the pus, collection of pus in the pleural cavity. We'll see the causes, the consequence, the clinical features, the chest x-ray, investigations, treatment. Alright. So, empyema thoracis is defined as a collection of pus in the pleural cavity. It's because of a complication of pneumonia or a rupture of an abscess which was already present nearby. So, like near the pleura, there is a diaphragm. So, it could be a subdiaphragmatic abscess, and underneath the diaphragm, there's a liver. So, it could be a liver abscess. These two abscesses could rupture into the pleura, thereby causing empyema thoracis. The condition is commonly one of the sequelae of staphylococcal pneumonia. It can also occur secondary to pneumonia, caused by pneumonia causing pneumococci. Apart from that, it can be gram-negative bacilli and also mycoplasma. Clinical features include three main things. Because the pleura is supposed to be empty or it's supposed to have very little amount of pleural fluid, and now it is going to occupy majority of the space of the thorax, the lung, which is supposed to occupy the majority of the thorax, is going to suffer the brunt. So what happens is that the lung is not able to do its function properly because of the pus in the pleural cavity, which is why the child is going to have breathing difficulty. And apart from that, because it's a pus, some sort of inflammatory reaction has triggered it. There will be fever along with systemic toxicity. There is clinical examination is done for the respiratory system. While looking at the chest, there is reduced movement of the chest with respiration. And we're going to do the percussion and note that the note which is noted is dull. It's a dull percussion note. And there is decreased air entry because what happens here is that there is no space inside the lung for even air to enter, which is why there is reduced air entry. And apart from that, whenever air is present, only vocal resonance is going to be there. But here, because there is no air, there is restricted entry for the air, there is reduced vocal resonance as well. Occasionally, what happens is an unnecessary problem, which is called empyema necessitans. That's right, empyema necessitans. What happens here is that the empyema sometimes will extend outside the pleural cavity, just like extracurricular activities. It's going to go outside the pleural cavity into the chest wall and the soft tissues of the chest wall. And this is going to present as a pulsatile swelling on chest examination. We can do a chest x-ray to be surprised to look at the shift in the mediastinum. Why is there a shift in the mediastinum? It's because the pleural cavity is going to be filled with pus and it's going to push the lung to the opposite side. Apart from that, the CP angle, otherwise called the costophrenic angle, is getting obliterated. Usually it is sharp, but now because there is water, actually not water, there is pus. There is pus, which is why it's a fluid content, so it's going to obliterate the CP angle and make it blunt. And the third thing which we can see in a chest X-ray is opacification. Initially, the lung used to have air inside of it, but now there is pus, which is why it's like opaque. Pleural tap is going a diagnostic pleural tap shows a purulent material. The pus has WBCs and high protein and low sugar content. I'm just assuming the bacteria is eating up all the sugar and it's building up proteins, and that's how I remember high protein and low sugar. Gram stain and culture may show causative organism. Empyema should be differentiated from other causes of pleural effusion, especially if it is due to tuberculosis or neoplasm. Treatment consists of antibiotics against staphylococci because staphylococci is going to cause the sequelae of empyema thoracis, which is pyothorax basically. Staphylococci, anti-staphylococcal antibiotics such as cloxacillin, vancomycin, teicoplanin, and linezolid are used. Empyema has to be drained. It's managed using a continuous intercostal drain along with the underwater seal. After antibiotics and drainage, even then, if the lung is not expanding sufficiently, we are expecting loculations to be present in the pleura, for which we are doing a CT scan. The CT scan may show loculated empyema, that is a localized collection of the pus, or it can be also thickened pleura. For that, we might have to do decortication either by thoracotomy or thoracoscopy. Thank you.